Good afternoon. Thank you so much to the organizers for this kind invitation. I am beyond humbled to join this esteemed group for this presentation. And I will figure out how to use the pointer. There we go. These are my disclosures. I'll begin with a case presentation, and I think this is really representative of a lot of the discussion that you've been hearing today so far. This was a patient that I took care of recently, a 35-year-old woman with a history of early onset type 2 diabetes who was already on insulin therapy and presented with worsening chest pain at rest. She's originally from Belize and came into the ED with really unremarkable exam and vital signs, but her troponin level went from 0.01 to 0.69, and the resting echocardiogram showed apical wall motion abnormalities. She proceeded to the cath lab and was found to have a proximal LAD lesion, and I apologize for not showing the post-PCI result. I think that's gonna hurt Roxana to not see the result, but unfortunately, post-PCI, she was rehospitalized for significant anemia requiring transfusions due to severe vaginal bleeding on DAPT. So I present this case to begin the discussion to say, what are the mechanisms that led to premature MI for her and in women in general? And we've heard a little bit of discussion about that so far. But could this sentinel event have been prevented? And further, could her readmission have been prevented? Were there things that we should have thought about in a menstruating woman before placing her on DAPT? So with that in mind, I have three objectives for today's discussion. First, defining disparities in MI and coronary heart disease at the intersection of sex with race and ethnicity. Second, with place-based disparities. And to end with identification of disruptive strategies for health equity with a focus on these understudied, underrepresented, and underreported populations. So to start out, we've heard some excellent discussion about really the heterogeneous risk of MI in women and the intersection of a variety of clinical, biological, and social determinants with sex and gender. And really this intersectionality of sex with a variety of other contextual factors that one may identify with, including one's age, race and ethnicity, nativity, gender, and disability, are at the core of understanding health disparities in vulnerable subpopulations of women. This is not a graph that is unfamiliar to this audience. We've heard it presented many times, and I think the reason it keeps coming up is that this is so striking. If we look in this observational cohort study that's representative of the US population, from 1995 to 2014, there were over 8,000 acute MI events, and a third of them occurred in adults 35 to 54. And in that red line, what you see is that the proportion of events happening in women is increasing. Importantly, as we stated already, that in addition to that increase, women are not leaving the hospital being on appropriate therapies, and that doesn't differ whether it was an NSTEMI or a STEMI. So the first intersection that we'll talk about is sex with race, and this is not a surprise to anybody in this room that women are underrepresented in clinical studies. That first graph demonstrates 60 trials of lipid-lowering therapy that we know is at the core of prevention, primary and secondary prevention for MI. And while the number of women increased from about 20% to a third, it's still abysmally low compared to what we know is the prevalence of women having an MI. Second, the intersection of race with sex. We don't have great data on how underrepresented Black women may be in these clinical trials because the numbers are already so low. In this recent study that looked at Black residents enrolled in cardiovascular drug trials between 2006 to 2020, this included 24 new drugs approved by the FDA during that period, and yet the participation to prevalence ratio for Black to white individuals was less than a third. In lipid-lowering trials, it was 0.02, so abysmally low. If we think about the changing racial and ethnic demographic in the US, this is only going to become a bigger and bigger problem. If we want to get ahead of this, we need to think about the different race and ethnicity groups that need to be represented in our clinical trials, in our observational cohorts, and in our studies. And we need to move beyond aggregated large categories, particularly for Asian and Hispanic subgroups, and shown here are data from the American Community Survey of various identities in terms of disaggregated Hispanic and Asian subgroups that are rarely identified in clinical studies. And why is this important? Because without reporting on disaggregated race groups, we won't know what the disparities are. And this was a really nice piece in Health Affairs written by Tina Cow that looked at what information we need for racial equity, and without investing in data disaggregation on a population level, on a clinical level, in a care setting, we're not going to be able to have that information. This is recent data that's just in press now, led by Nilay Shah, looking at disaggregated Asian subgroups from the CDC Wonder data between 2003 and 2017, and you see there's significant heterogeneity. In particular, South Asian women have a much higher risk of coronary heart disease mortality. If we think about nativity at the intersection of sex and race, that will also enhance our understanding of vulnerable populations. In the first graph, you see that between men and women, there's a greater difference between men who self-reported coronary heart disease who were born outside the US compared with women. However, that difference changed depending on how long someone had lived in the United States. And so on that panel on the right, you can see individuals who had lived in the US for more than 15 years had a much higher prevalence of coronary heart disease compared with those who had lived in the US less than 5 years. While a lot of times this is reported as a healthy immigrant paradox, understanding the contextual factors that lead to increasing risk with the longer residence in the US or acculturation are just as important if we want to address disparities. The role of gender, we've talked a lot about biologic sex or sex assigned at birth, but it's just as important to understand an individual's gender identity. And this really excellent statement for the American Heart Association assessing and addressing cardiovascular health in people who are transgender and gender diverse really put this excellent conceptual model together looking at distal stress factors related to discrimination, rejection, and victimization, as well as proximal stress factors, and what resilience factors could be promoted to improve outcomes in these vulnerable populations. I'll end with one more, and this by no means is an exhaustive list of contextual factors that need to be considered, but focus on disability because women are much more likely to be disabled than men. About 1 in 4 women in the United States have a disability related to mobility, cognition, vision, hearing, and yet care is very different, particularly for preventive care. A lot of the data in this area, including this study from the NHIS, focuses on gynecologic care where there may be particular challenges, but we know it's also the same for preventive care for cardiovascular, particularly around smoking cessation. Healthcare for women with disabilities and population-based evidence of disabilities, as well as access to care, has been studied in very few papers. And I think one of the challenges comes from whether or not this population gets identified as a health disparity population. From the NIMHD, NIH defines health disparity populations as racial and ethnic minority populations, less privileged SES populations, underserved rural populations, and sexual and gender minorities. Disabilities is not included in that list, and it intersects with a lot of the factors listed there, but without that recognition, I think it's going to be very hard to have studies that are specifically focused on these vulnerable individuals. In addition, how we improve access to care, we've talked a lot about making sure people are getting the right diagnosis, they're getting the right treatment. They need to be able to get in to see the doctor. And this excellent viewpoint really highlighted 3 specific axes that are necessary to improve care for individuals living with disability. Physical access in the environment, being able to receive care where someone is able to get onto an examination table. Policy and procedural access, allotting the amount of time that is needed to care for a complex patient with disability, and communication access, ensuring that appointment time and follow-up as well as adherence are discussed at a speed and at a level of understanding that is appropriate. So if we understand those identity and individual level disparities, how do we think about sex with place-based disparities? We know that there are significant rural-urban disparities in myocardial infarction as well as cardiovascular disease broadly. These are excellent data from the Medicare fee-for-service that looked at 30 and 90-day mortality for MI in rural versus urban hospitals. Now, these models and these data are really for the overall rural compared with urban population, but we know that there may be additional disparities among women. Shown in the left panel are 30 and 90-day mortality for NSTEMI and for STEMI. And in both of these conditions, rural hospitals had a much higher mortality, even in the short term, between 30 and 90-day outcomes. And one of the things that may account for this are observed procedural rates. In rural hospitals, there were fewer cardiac catheterizations, fewer PCI, and fewer CABG performed. If we move beyond the county level labeling of rural versus urban and think about the neighborhood or census tract level, we know that there are significant disparities even within a major metropolitan area. And shown here are 3 of those in the United States for Chicago, Washington, D.C., where we are now, and New Orleans. Now, these 3 cities were chosen because they unfortunately have the largest life expectancy gap in the United States, where Chicago, where I'm from, has a 30-year gap within an 8-mile radius in the city. And the leading cause of that is coronary heart disease. In the lower set of panels, what you see is that the areas that have the highest social vulnerability, measured by the dark red or by the social vulnerability index, are the places that have the highest coronary heart disease prevalence. So this is not something that we can tackle at an individual level, but need to think about how we tackle at a community level and at a broader level. There are many potential factors at a neighborhood level that could be accounting for these differences. We think about access to care, we think about food environments, physical activity environments. But structural racism and police violence particularly may be an important aspect of how we approach cardiovascular care, particularly in women. In this recent study led by an excellent postdoc at Northwestern, we looked at an electronic health record-based cohort of women who were in our health system between 2008 and 2018, and we looked at 2 specific populations of women, pregnant people and those who were receiving primary preventive care. In both of these populations, what we saw were neighborhoods that had a higher number of complaints regarding police violence that were formally filed, had higher risk of preterm birth as an important cardiovascular risk enhancer, and of cardiovascular disease later in life. And these risks were similar regardless of adjustment for other neighborhood level factors. One of the things that we know is a serious problem in Chicago is a legacy of redlining and residential segregation. So even when accounting for other neighborhood level factors, we still saw this significant increase in preterm birth and coronary heart disease. One potential way to think about this conceptual framework that links adverse pregnancy outcomes and cardiovascular disease, as we've heard, which is an important risk-enhancing factor, is thinking about these racist practices and policies that are in place that differentially affect both health-promoting factors as well as health-harming factors, and how that effect on weathering, health behaviors, health factors contribute both to adverse pregnancy outcomes and cardiovascular disease. Not only are adverse pregnancy outcomes a risk-enhancing factor for the birthing individual themselves, but it also begins a lifetime of health for the offspring in the wrong way. So if we summarize the initial discussions, I have 3 points that I hope that you leave with. Understudied, underrepresented, and underreported populations of women experience a disproportionate burden of coronary heart disease risk. A multitude of factors across the life course influence the cardiovascular health of women, including the intersection of place with adverse pregnancy outcomes and coronary heart disease risk. If current trends continue, the growing burden of MI is likely to be experienced disproportionately among women, with widening disparities across generations. So what can we do, and what are potential action items if we think about the initial aspect of the year of 2020 being one of awareness? What do we do to make these action plans, and how do we identify disruptive strategies that can focus on these vulnerable populations? So as a card-carrying preventive cardiologist, no disrespect to the interventional cardiologists in the room, I'd be remiss if I didn't say that one of the most important things is that we have to prioritize population prevention, and the reverse pyramid focusing on increasing population level impact as we move from tertiary and secondary prevention, which are of course critical, to primary and primordial prevention. You've seen this data from the POM registry, again highlighting that this was across 140 US community practices in 2015. So this is very contemporary data. And in over 5,000 individuals, women were much less likely to be on a statin, as well as never to be offered a statin. And I think that's one of the most striking statistics in this data, is not just that they were less likely to be adherent, or there were patient-level factors where they stopped their statin or they had side effects, but they were never even offered one. Inclusivity in research, we heard an excellent outline in how we can improve recruitment, enrollment, and retention of women in research, and this excellent diagram from the commission also highlights key factors that are needed. But I think one of the things that we have to work on is messaging. And this message is so prevalent that's out there, and this was a news article from about a year ago that focused on why women are underrepresented in clinical trials, but the headline is what bothers me. Recruiting women for cardiovascular research is harder. Women are reluctant to participate despite being more likely to die of heart disease. And so we have to change that narrative. It's not that women are less likely or don't want to be included. Are they being asked? Are they being provided the resources that they need to take care of their child or their elderly parent who they're primarily responsible for? Are they being told why they should be engaged in the study? And so I think that's really critical to how we're going to move forward and change this. If we think about what are the things that need to change, it's not just women. I think we heard that earlier today. This is not a women problem or a female problem, but this is a societal problem. And so we have to think about all the other pieces that are in place, and that includes scientists, clinicians like us in the room, but also grant agencies, industry sponsors, independent societies, journals, academic institutions. So this excellent review in JAC that focused on what is needed to improve gender equity in clinical trial leadership are the same principles that we need to apply to improve outcomes and inclusivity in research. And it can be done. So this is a great example, I think, of the Go Red for Women registry that has recruited over 17,000 women in the past year to participate in the Go Red for Women registry and participate in research. And one of the key things when you log into the website is really about empowerment. It's sharing why women want to be involved in research, why they may gain from this, what information is needed. And so I think that will be equally important as we move forward. So I'll conclude with this proposed roadmap that really came and it was inspired from the commission report itself to achieve equity, and think about 3 levels that we can act on. Prevention, so really beginning early with primordial prevention and primary prevention, even before birth, in that preconception and conception period as we think about the next generation and the pregnant person themselves. MI management, we heard a lot about diagnosis and treatment, making sure that individuals are receiving not just the right treatment, but receiving the right therapies. And policy initiatives, so ensuring advocacy and policy changes that can support our awareness into action plans. Standardized sex and gender reporting also as a key important aspect of this, so that we can ensure that we are identifying disparities. You don't know what you don't ask about, and you don't know where there are disparities if we're not collecting and reporting on that data. Diversifying research participation and workforce and engaging with communities are all critically important, and addressing these factors across the life course. So I'll conclude there, and I'm really excited for the panel discussion. Thank you all so much for your attention.